Hello. Wanted to go over chapter 18 on preoperative care, since that's going to be our topic this week. It is a long slideshow, so I'm going to go rather quickly through a lot of the information, but I just wanted to let you know what is important to know, for you to know. In terms of talking about reproduction, where we are right now, um, we're seeing C-sections, which is a surgical procedure. So there's pre-op prep for that. There's during the surgery, and then there's post-op. So it's a good introduction. So the chapter starts out talking about what types of surgery, who gets surgery, different reasons that patients that you see might be wanting surgery. We also see it in pediatrics, a lot of appendectomies and tonsillectomies we'll see as well. So elective surgery, something that we plan, emergency surgery, like a perforated appendix perhaps, or an emergency C-section. A lot of surgeries now are more inpatient, are more same day surgeries, things that we used to keep people, for overnight or 2 or 3 days or even a week in the hospital. We no longer do. They come in, they have the surgery, they go home. So that presents some challenges as well. And those can be done in different settings, in a hospital setting, in an outpatient ambulatory setting. The chapter goes through a pre-op care case study. So they're doing a pre-surgical workup for the client. And so what is your role? What are we going to do preoperatively? So we talked about, you've learned about how to do assessments and how to take health histories. And so those are very important things to know how to do in this instance. So you want to make sure that you have the right patient, talk to them about, have they had surgery before? What is their experience with that? Also looking at any tests that they're supposed to have prior to the surgery. And one of the most important things to do is be able to identify potential risks and complications of the surgical procedure. So is there something in their history while you're talking with them that kind of comes up as a red flag in terms of, ooh, they might have trouble either during the surgery or post-op after the surgery. And so you always want to look and see the history of what information you have. And oftentimes sometimes it's on the day of surgery even, so that I think makes it even a little more difficult to recognize potential problems. Sometimes it can be a week or two prior to surgery, and it can also take place in different settings. But we also want to find out about their allergies. And I think the emotional state and readiness is really important. I think that gets missed a lot. And also to determine what are the client's expectations. What is the expectation that they think is going to happen? So I think that's important, especially if we're talking about a cesarean section scenario. What elective versus emergent. What is the client's expectations? What are the partner's expectations of what's going to happen before, during, and after the surgery? So our client here is accompanied by her husband. She has 2 school-age children. Her breast biopsy was positive for cancer, and she anticipates that the lumpectomy will remove all the cancer. So looking at that, think for a minute, what are potential problems or things that she might have to deal with after, well, in preparation for the surgery and after the surgery? There's many things on different levels. And so what are the risk factors? What plan to ensure safety can we put into effect? Again, talking about different factors, psychological, physiological, and then making sure that she's aware of the site, that you're going to have the correct surgical site, talking about any medications that are needed pre-op, post-op, finding out what medications they're currently on, any herbals, and any of the preoperative testing that's been done. And then also cultural and ethnic factors that may affect the surgical experience. That's going to keep coming up. And then, has the surgeon provided enough information so that the client can make an informed decision. And then we just verify that the consent form is signed and witnessed. So our client states that her mother and aunt have a history of breast cancer resulting in mastectomy, and she's very anxious and fidgeting. So the next section of the PowerPoint goes through the body systems and assessing different body systems, and as well as the psychosocial assessment. And so, of course, you could read through these slides. I'll try to highlight anything because as you can see, there's like 33 slides there. So a lot of things that we've already talked about in class, and communication, using translators, common words that the client understands, and understand that if they're anxious, they may not be comprehending. So it's good that they bring a support person with them. And hopefully if we can give them some information and they can take it in, then that will help decrease their anxiety. They might also have beliefs or customs or things that conflict with what we want to do in surgery. So we need to identify those and talk about them. Different fears that the person might have, pain is always a big thing. What's going to happen afterwards? Is everything going to come out the way I think it's going to come out? And so you want to kind of try to talk to them about that, as well as any alteration in body image. When we think about a C-section, we know that, there's going to be pain after that. And then in terms of body image, having a scar, having an incision. And then other fears in terms of anesthesia, what type of anesthesia is going to be used, and then disruption of life, like what's going to happen after surgery. Could there be a disability? Who do I let know about the surgery? Are there going to be any consultations that they need afterwards? And hope is the strongest method of coping. Assess for that and support it, and never deny or minimize something that the client is saying. Again, we talked about that when we talked about effective communication. And so the client tells you she has a history of hypertension, and she recently was diagnosed with type 2 diabetes and currently controlled with medications and diet. So when you think about that, how can hypertension affect surgery, the actual surgery, and post-op recovery? And also then what can type 2 diabetes, what effects can that have on the client? Are there certain things that we need to take into consideration as we prepare them for surgery? And then looking at past health history, any inherited traits. We're going to talk about malignant hyperthermia. I think you already talked about that, or we'll be talking about that in pharmacology as well, in terms of medications, being able to recognize it, and then giving the medications to help with that. There is a familial component to that, and as well as looking at the signs and symptoms. And then what current medications, over-the-counters, herbs, recreational, alcohol use, do they smoke? Because that can affect outcomes as well. Do they have any allergies or drug intolerances? Latex allergy, especially. Most everything is latex free now, but there might be some things that have latex in them. So we want to be aware of that and make sure that we let people know or mark it on the chart so that people are aware. So the client is taking hydrochlorothiazide and glipizide, and also a multivitamin, fish oil, and a daily low dose aspirin, so 81 milligram aspirin. She has an allergy to penicillin, and she gets a rash. So that is, to me, would be a true allergic reaction to a medication. So you want to make sure that it is a true allergy. You're going to document that they say they have the allergy, but they may just say they get nausea. And that's not necessarily an allergic reaction. The rash, edema, those types of things would be an allergic reaction. And also the clients had no other surgeries in this case. So that might be pretty scary. They're going for a lumpectomy as their first surgery. And then moving back to the assessment, going through the systems, again, your head to toe, any other diseases, any specific areas. So cardiac, sometimes they'll do a 12-lead EKG. Always we're looking at for venous thromboembolism prophylaxis, getting them up and moving, and also doing assessments, the assessments for that. And then respiratory system, any infections that they might have. We don't want to do surgery. And so then also if they have asthma, for example, they might have, COPD, chronic obstructive pulmonary disease, then they're at risk for lung collapse and hypoxemia because the airways aren't going to react well to the anesthesia. They can have bad reactions. And so you would like them to stop smoking at least 6 weeks before surgery. That's not always going to happen. And then if they have histories of sleep apnea, or if their BMI is high, they're obese, you want to make sure that you let the surgical team know, or if there's any airway deformities, like perhaps they've had if it's children, maybe a cleft palate, or some airway issues there. Checking the neurological system, looking at their reflexes, following commands, their genitourinary system, any previous diseases or renal problems, at risk for impaired wound healing with the diabetes. And then have they had any renal function tests? Always need to ask about pregnancy, if the client might potentially be pregnant, if they're in menopause, any medications that they're taking. Check the gentleman for prostate problems. And then liver, any problems with their liver. Again, just going through all the systems. Skin, is there any bony prominences, things that need to be maybe padded, or put the person at extra risk for pressure injuries? And then is there any piercings or tattoos, anything that we need to take note of there as well? Musculoskeletal, any restrictions, because we want to make sure that they're mobile and that we can get them moving and keep their pain under control. And then depending on the different types of anesthesia, where they're if it's a general anesthesia versus like an epidural or a spinal, or if they have neck issues or spine issues, then it might be difficult to intubate them and manage the airway. That's why the anesthesiologist has purview over all of that. Endocrine system, talked about diabetes. Also, there can be issues with thyroid that can affect healing as well, hypothyroid. And so when you're thinking about our client with her history of diabetes, what do you want to ask her? What is important? What are you thinking about in terms of her normal morning routine that is now going to be different because she's having surgery? And so let me go back to that. Sorry. And so what you'd be thinking about, hopefully, would be her medications. Like, what medication is she specifically taking? When does she normally take it? She's going to be NPO, nothing by mouth, prior to the surgery. And so we're going to want to check her blood sugar before we would give insulin or before we would do anything like that. Because if she's very hypoglycemic, we could potentially give D5 or D10 to give her some sugar in the IV. That will start for her, but we need to keep an eye out for that, and she's probably not going to want to take her insulin in the morning, because that'll just drop her blood sugar. And then post-op, we're going to have to watch out for that as well to monitor her blood sugars. Endocrine, the insulin dosage, making sure that the physician knows and the anesthesiologist as well know the history and the medications that she's taking, and what time that she's taking those. And here it's the thyroid problems, because the metabolic rate can change. And so she's not going to be taking any thyroid medications, although I don't think she was on any, but if the client has any, they're not going to take that. So that can affect them throughout the day. And then with different types of corticosteroids. So these are different things. We'll learn about Addison's in third semester, but different steroids can affect, like the stress. You have to increase the dose of the steroids because they're not working properly with the stress. Immune system, anybody with a compromised immune system. Now, if she is having a lumpectomy, if she has cancer, then that is going to put her in an immune compromised state right there. And so if there is an infection, they might cancel the surgery. Patients with chronic infections, they might just go ahead and do the surgery because the infection's not really going to go away. So we have to get our proper PPE and all our infection control procedures. And then fluid and electrolyte status. So for example, like a colonoscopy, you have bowel prep that you're doing. And so that empties everything out of you. And so she's also on the hydrochlorothiazide, which is a diuretic. So she's going to be voiding, but then she'll also be NPO. So we have to watch for that. And then the serum electrolyte levels. Also with anesthesia, you can have vomiting and diarrhea, so that can also affect the fluid and electrolyte status. So we kind of just said that. There we go. Nutritional, so customized care for patients with nutritional problems, so extra padding to underweight patients to prevent pressure ulcers. There could be protein or vitamin deficiencies, dietary habits, that might affect recovery. Like a lot of people have to have their coffee in the morning, and you can kind of go into caffeine withdrawal, which is not good. And they may be NPO for 12 hours or a couple hours after surgery as well. So you want to be monitoring their nutritional status, and for her as well, her blood sugars. Obesity is a risk factor for surgery because you can have slower wound healing. There's also, we'll talk about what happens to the wound, like dehiscence, where it comes apart, it tears apart, or infection. There's also a lot of stress then that's put on the cardiac and pulmonary systems, which is difficult for the body to control. And so when you're doing your assessment as well, you want to be able to, well, Joint Commission requires a history and physical, which is what we don't do the physical. The physician would do that, but they want to make sure that we've checked with the client, and then the care provider to the anesthesia care provider, that's what ACP is, anesthesia care provider, to rate the patient for anesthesia administration. So the anesthesiologist should always be coming in and talking to the client ahead of time to ask about their history and see if there's any risk, and talk to them about risks and benefits and different options for anesthesia that they have. So the physical's done. We've looked at the diagnostic studies. We monitor the blood glucose. So those are all things that we're doing. And so now that we've done the initial health history assessment and we've done our systems assessment, what is it as a nurse that we need to be doing for our client? So the patient needs to know, they have the right to know what to expect and how they can help participate in their healthcare to make everything go smoothly and have a good outcome. And so the more pre-op teaching that you can do, the better. It increases patient satisfaction. They know what to expect. It can reduce their fear and anxiety. And it also may help decrease any complications, like because they feel better, maybe their pain won't be as bad, or they won't vomit. So those would be good things. And I think the more they know, the more we can help them understand what the procedure is, the better. And so the problem is that we don't always have a lot of time to do all that. So we have to look at the needs of highest priority. So when we've done our assessment and we've done our health history, seeing what things are most important, that's what we want to address. Always give them handouts. That's always good. Written information, make sure it's in a language that they can understand, or make sure that they can read or have somebody that can read it to them. Safety is always very important. And the pre-op teaching, they'll do it during the interview process, and then you might be the nurse that is in the same day surgery suite doing the pre-op preparation. And so then you have even less time to do pre-op teaching. So you would like to assess what the client already knows about the surgery. So you don't have to not waste your time, but waste your time teaching them things that they already know. You want to focus on and ask them, what are your concerns today? How can I address your concerns? Is there anything I can do to help decrease any anxiety that you might be having? So that's several days before surgery. And then what teaching do we want to give our client before the day of surgery? And then what does she need to know on the day of surgery? So being that it's her first surgery, we're going to talk to her about what to expect. The day of surgery, again, I would walk them through, here's, we're in this area, then we're going to take you here. They're going to give you the anesthesia, do the surgery. Then when you wake up, you're going to be in the post-anesthesia care unit, PACU, or recovery room, whatever they call it. Oops, sorry. Keep going ahead of myself there. And so they know, and she's going to want to know, well, when can my husband come in and be with me? Am I going to be in pain? Do I have to lay down? When can I eat or drink? Or what about my medications? Those are kind of things that you want to address on the day of surgery. And so there's sensory and there's process and there's procedural. Those are the types of information teaching that you would be giving. And so another important thing is to always, always document what you have, the education that you have provided, so that the client cannot come back and say, oh, well, they didn't teach me this, because they may not remember, because they're going to be all nervous about the surgery. And so we want to try not to duplicate information, and again, evaluate the patient learning what they already know. And then once we've taught them something or given them some information, to evaluate their understanding of what we just taught them. So again, the nursing process coming back around. So in terms of things to know, to teach, the deep breathing and coughing, splinting with a pillow if they need to cough, depending on where the incision is, and early ambulation, if they're going to have an IV or any monitors on, post-op, and then surgery specific information. Excuse me. We want to make sure that they get to where they're supposed to be on time on the day of surgery. And so especially for ambulatory surgery, when you're going to an ambulatory care center, excuse me, we want to make sure, I mean, they're there already doing the interview more than likely, but when do they have to be there? They should be there early. Where are they going to walk into the building? Do they have to register? Where are they supposed to park? And then once they're done, who's going to pick them up? What should they be wearing or bringing? Like, don't bring anything. Wear comfortable clothing. They usually don't want jewelry or things that are going to get lost or stolen. And then fluid and food. When's the last time they can eat or have something to drink? What medications would they be allowed to take or not? Informed consent, we're just making sure that that's signed and in the chart. Any consents also for blood transfusions? Do they have advanced directives or durable power of attorney? All those types of that paperwork we should be asking about, and make sure that is in the chart. And then the consent for surgery. And then again, the surgeon, the physician, is ultimately responsible for obtaining consent. So anytime there's a question, we would refer back to the physician and hopefully have them come back and address the questions. And the client can change their mind at any point in time. They can say, no, not this. I'm not going to have this happen today. And that's fine. That's their right to do that. And so legally appointed representative of the family can consent if the patient is a minor or mentally incompetent or unconscious. And we talked about emancipated minor, is younger than legal age, but able to provide legal consent. Also in a medical emergency, if it's to preserve life, preserve serious impairment, or the patient's incapable of giving consent. We kind of had talked about that when we talked about consents in week 1, all the way back in week 1. So our client signs her consent in the presence of the surgeon in his office before the day of surgery. So that's good. Does that mean that when the client comes in and we're the pre-op nurse, that we don't ask about consent or ask about their understanding of the procedure that's going to happen? No, because they might have changed their mind between now and then. What we see sometimes in OB is that the client will have talked to the OB in the office before they're delivering, or maybe it's going to be a planned C-section, and they want to also have bilateral tubal ligation. And so they've signed the consent for the C-section and the bilateral tubal ligation, the BTL. But I cannot assume as a nurse when they come to have the C-section that they still want to have the BTL. So I have the consent for that on the chart because it's been signed, but I need to double check and make sure that that's still what they want and they understand how that procedure is going to happen. Because they could say, no, I don't want to have that done anymore. And so again, the day of surgery, right? Assessment and communication of pertinent findings, making sure everything's on the chart correctly, any final teaching that needs to be done. Getting as the nurse, right? We're getting our baseline vitals, making sure the skin is prepped, making sure that the surgical site is identified. The surgeon should come in and mark the site, but we want to make sure that the client will tell us, it's my left breast or my right breast that has the cancer in it. And document. I like when I've gone in, they've had the warm blankets or the bear huggers that keep you nice and warm, and that's always good. You're going to start an IV so that they have IV access. There may be some pre-op meds to give that will help with some balanced anesthesia there that you're learning about in pharmacology as well. So our client gets there, and how are you going to help her get ready for the OR? We just talked about a lot of those things. Her husband's probably with her. The support person can usually stay until the client needs to go to the holding area prior to surgery. No cosmetics, looking at skin color, they really should have the nail polish off or artificial nails off to be able to put the pulse oximeter on. They will get their name band on. Any allergy bands should go on. So we want to make sure that those are all correct and double check. Always remember name and date of birth. And then valuables don't stay. They get given to the support person. You're going to take off. They should remove their glasses, contacts, any prosthetics that they have, dentures, jewelry and piercings removed. If they're going to be doing electrocautery to stop any bleeding. You do, though, want to leave hearing aids in place up until they go into the OR so they can hear what you're saying. And then once they're in anesthesia, they can stay in, and then you want to make sure that they are in post-op as well so they can hear everything. Make sure they go to the bathroom before surgery, before their pre-op drugs. Why before their pre-op drugs? If we're doing balanced anesthesia and we're giving them something to kind of calm them down, they're going to be dizzy and woozy potentially, or orthostatic hypotension. So we want to make sure that the side rails are up, that they void before before surgery, and that when they get back in the bed or on the gurney, that the side rails are up. That's like the basis of safety there. That side rails are up, and they're probably going to have put a Foley in if they're under anesthesia, but not always. If it's a quicker surgery, maybe not. And if we've emptied the bladder, then that's a good thing. There may not be a lot of fluid anyway if they've not been taking liquids in. And then here you go. Here's your pre-op meds. Benzodiazepines, one of the things for sure that will help calm them down. Anticholinergics will help to decrease the secretions, which is good. Antiemetics, we see that a lot. Also antibiotics to prevent infection. So we're doing that prophylactically. And then they might also administer opioids. If they have other medications that they have to take, like they're not going to take their insulin. They may want them to take the beta blockers, but that's going to calm the heart down. So it would be up to the physician and the anesthesiologist to decide. And the same thing with eye drops, because they can have systemic effects as well. And then it's time to go to the OR. Once we get everything ready, usually on the gurney is what I've seen. And then you have to do a handoff communication because you're going from the pre-op area where you are and you're going into the holding area where the nurse is then going to take them into the OR. after that. So the support person is going to go to the waiting room. They're not going to come with you to the holding area. The exception to that might be pediatric surgery. I know I've asked to go with my kids in the past to be in the holding area with them, and then I'll go to the waiting room. Sometimes they'll let you do that. But and then you give your S-bar and then you go back and find your next patient. And if you're the pre-op nurse, you're only seeing the pre-op patients. You're not going to see them after the surgery. In the recovery room, it's different staff in the post-anesthesia care unit. So you're going to give IV midazolam as ordered to prepare to hand her off to the OR, and you're going to put your S-bar together. And so I would encourage you to think of, what you would say, what the situation is, what she's there for, what her background is, what you've assessed. Is there anything like the insulin, the hydrochlorothiazide, anything else that's going on? What are her current vital signs? Those are important things to know. And then back to nursing management, any special concerns, culturally competent care, what is their expression of pain? Are they stoic? Are they feeling like they're in a lot of pain? It's also important, I think, to ask the support person or the person that's there, what are your expectations? What have you been told about how you might have to help take care of the client afterwards? And, will the support person be helping you, make decisions, or are they able to verbally express needs? If it's a culture where they're used to other people speaking for them, that person isn't going to be there with them. So they're going to have to let us know themselves. So we want to try to encourage that when possible. And again, a person's pain is a person's pain. Geriatric considerations. So we want to take into account the body's metabolism and how things change over time. Might be very overwhelming, especially if the client has cognitive issues, Alzheimer's, for example. They may not want to be in the hospital. A lot of these surgeries are in ambulatory care centers, which are not in a hospital. So sometimes that's nice. But a lot of times after some of these surgeries, they do have to go to a nursing home, to a long-term care facility for the rehab that they might have to do. There are increased risks for the anesthesia and the surgery as well, as to how the body metabolizes the medications and the anesthesia. And they could have other sensory deficits, hard of hearing, or have visual deficits, in addition to the decreased cognitive function that make things difficult for them. And so as we come to the end of this particular PowerPoint, there's a couple of practice questions here. So the 68-year-old male is scheduled for a hernia repair at an ambulatory surgical center, and expresses concern that he will not have enough care at home, and asks if he can stay in the hospital after the surgery. And so which response would you as the nurse provide? What is the best response to figure out, he says he's not going to have enough care at home. And so your options are who's available to help you at home after the surgery. I'm sure you'll be able to manage at home after surgery. It's a simple procedure. We will teach you everything you need to know to be able to care for yourself after surgery. Your health insurance will pay for inpatient care only if complications develop during surgery. That's probably true, but probably not the best thing to tell them. I'd actually want to find probably some more information if there's anybody available or who's at home. So B and C are not the best answer either. So A would actually be the best answer. Is there anyone, do you have anyone available at home to help after the surgery, or tell me what your home life is like? Tell me who's there. And then which preoperative instruction is appropriate for all patients? So techniques of deep breathing and coughing, descriptions of the planned surgical procedure, physical procedures or prep required before surgery, withholding of all oral fluids or food after midnight on the day of the surgery. So for all patients, I would have to say that probably techniques of deep breathing and coughing. That would be my choice, because we want them to be able to do that for their aeration, for the airway. the planned surgical procedure is going to be different for different people. The procedures and prep before surgery is going to be different. And then depending on fluids and food after midnight on the withholding of that, sometimes it's not after midnight. Sometimes it's different time frames depending on when the surgery might be scheduled. So the answer for that would be A. And I believe that is the last slide. And so things to take away from this particular pre-op would be our nursing management, making sure that the informed consent is on the chart, looking at our cultural influences on how our client is going to react to the surgery, thinking a little bit about that balanced anesthesia, safety precautions for that. And that should do it. So that would conclude our preoperative PowerPoint. And so we will move on to intraoperative and postoperative in 2 more presentations. So thank you.